thanks to everyone for joining. In my first slide, I'm merely showing regulatory statements on the nature of the slides I'll be showing and referencing the scientific publications and the indications of use for the FibroScan technology. First, I'd like to cover just a little bit of terminology so that I don't throw anyone off. When I'm talking about the FibroScan technology to perform elastography of the liver, the name of the operating principle is vibration-controlled transient elastography, commonly referred to by the acronym VCTE. So from this point forward, when I use the term VCTE, please appreciate that I'm referring to performing liver elastography with the FibroScan device only. I'm showing you here the existing clinical practice guidelines which span the disease spectrum of liver disease. And I've highlighted the top 3 guidelines that reference the FibroScan technology and listed as a first-line test for doing diagnostics in the liver in a non-invasive manner. I will be referring to these various clinical practice guidelines during my presentation. Now I would like to do a quick reference for what many of you are probably accustomed to using when you had your FibroScan installed, for those of you that are FibroScan users. These are the prior threshold values that would have been provided at the time that you received your training on the FibroScan. Echosens does not take a position or issue threshold values for VCTE. All we do is we suggest what we think is the most current and most credible sources of threshold values, and then we let the provider make their own decision about what they wish to use. So what I'm showing you here are the threshold values that many people use based on a review article back in 2014 by Bonder and Ofdahl. We have a great deal new information, and that is the basis for today's webinar. In May, just before DDW, the AGA issued elastography guidelines. I'll be referencing those frequently in this presentation. That was followed up in July with the AASLD fatty liver guidance document. And then finally in August, there was a New England Journal of Medicine review article published by Tapper and Ofdahl that I will be referencing as well. I will span all 3 of these documents to provide you the latest information on threshold values that are in those publications. You should have received an invitation to a November 1 webinar that's going to be done by Dr. Tapper, the co-author of the paper I just mentioned, on the evolving role of invasive and non-invasive assessment tools in liver disease. I will mention Dr. Tapper's work several times during this presentation, but for detailed information, I suggest you join us for this webinar, which is sponsored by the Chronic Liver Disease Foundation. Now let's get into what are the more recent published VCTE cutoff values, and I want to start out with the specific disease of hepatitis C. So everything I will be showing you here for the next few slides will specifically relate to HCV guidelines. Going all the way back to the original issuance by the AASLD and the IDSA of the clinical practice guidelines for HCV, they made that statement about 3 years ago that the most efficient approach to fibrosis assessment is to combine direct biomarkers and vibration-controlled transient elastography. So that position of combining the serologic markers with VCTE has been around for about 3 years. However, in that guidance document, they didn't provide any specifics on how to combine them and what threshold values might be useful and what would be the accuracy of those thresholds. So I'm going to expand on what they said and bring in the AGA elastography guidelines. Now, in the technical review of the elastography guidelines, they ask a series of questions and then provided associated guidance statements. And I want you to notice that they compared the accuracy of VCTE to serum markers, and they came to the conclusion that VCTE was more sensitive and specific than the blood serum markers, specifically referring to APRI and FIB4. However, they did not provide threshold values for APRI and FIB4. Further, they said that APRI and FIB4 were at least as accurate as the proprietary markers, such as FibroSure. Therefore, they were recommending the indirect biomarkers, which are free. They also issued guidance statements on what should be used as a VCTE threshold for advanced fibrosis and for cirrhosis, and the associated accuracy values. Here you see the advanced fibrosis threshold value that was issued, and this is in a nice table form that you can reference. And so you'll notice the threshold for advanced fibrosis that they're suggesting in HCV is 9.5 kilopascals. Now, that was set with a priority to have the best negative predictive value possible. Notice that they set those values. Here you can see a low risk prevalence of 99% and a high risk of 90. And what they were out to do here was they wanted to minimize false negatives because of the obvious health repercussions that would happen if you undercalled disease in a patient that indeed had advanced fibrosis. Here you see the cirrhosis threshold in the AGA elastography guideline, again, prioritized to minimize a false negative rate. And here you see a threshold of 12.5 kilopascals, which matches very nicely with what has been used for years based on the Bonder-Ofdahl publication. Finally, they issued two threshold values that never previously existed. They issued a threshold value for portal hypertension, non-hepatic surgical risk at 17 kilopascals, and they also issued an esophageal varices risk threshold of 19.5. And for the varices threshold, you can again see what the negative predictive value is. You will note that they didn't state negative predictive value on the portal hypertension line because there wasn't enough disease prevalence information to make that calculation. Finally, referring to the most recent New England Journal of Medicine review article by Tapper and Locke, they took it a step further and provided the first information that we've had on how to combine VCTE and serologic marking in a collaborative, synergistic way. And so what they're suggesting here is that the tests be done on the same day to eliminate variability from day to day, and to combine either VCTE and FIB4 same day, or VCTE and APRI, and then compare the findings of those two tests and look for concordance or discordant or indeterminate results. Let's take a look at what they're suggesting. Just as a reminder, this is the FIB4 online calculator. Many of you probably use this on a daily basis, and this brings into factor the patient's age, AST, ALT, and platelet count, and you merely click calculate and you get the value. Here's the APRI calculator using AST and also looking at platelet count. So what they're suggesting here with specific threshold values is here's the combination of using VCTE, and they recommend an advanced fibrosis cutoff of 9.5 kilopascals. And then they provide a high and low cutoff value for APRI that you can see illustrated above, and you see the associated accuracy of the two respective tests. They did not look at the accuracy that is achieved when you combine the two tests. And finally, here you see the combination of combining VCTE with FIB4 and those low and high risk cutoffs for FIB4. Now, just to exemplify this approach of same day VCTE and serologic marking, I want to give you a simple example case. So on the left, I'm going to show you some sample values. On the right, I'm showing the threshold values that they suggest for FIB4 and VCTE. So imagine that you did these tests and the FIB4 value was 1.1. Looking to the right, you would see that that would be a very low risk finding because it's less than 1.45. Then I'm showing an example of VCTE having a value of 7.0, which of course is low risk for fibrosis because it's less than 9.5 kilopascals. So in this case, what I'm showing you is synergistically using the two tests and finding concordant low risk values. This type of approach can be applied to a diagnostic algorithm that is suggested by Tapper and Locke, and merely working through this decision tree based on concordance, discordance, or indeterminate results. A little bit about hepatitis B. This is the information from the AGA elastography guidelines. Their guidance statement here is once again, as in Hep C, that VCTE has superior accuracy than APRI and FIB4, and then they provide a cutoff for VCTE. They do not make any suggestions on to how to synergistically combine the two tests. So here you're seeing in table form the AGA elastography guideline for hepatitis B, and you can see they're suggesting a cutoff value of 11, and again they're emphasizing high negative predictive value. Finally, in alcoholic liver disease, looking at the AGA guidance, what you're seeing is they suggest a threshold value of 12.5 for VCTE, and here you see the negative predictive value of doing that. Now, I want to emphasize in this table that what they're suggesting is this is the cutoff value for the abstaining alcoholic. As we all know, if an alcoholic was actively drinking, there would be a substantial inflammatory component which would elevate the stiffness not related to fibrosis. So we need to be cautious when testing alcoholics to be sure they're abstaining if you're going to consider using that AGA elastography cutoff. Finally, Nephal. Let's talk a little bit about what we have here. Now here I'm showing you for the first time recent statements from the AASLD practice guidance statement that was just published this summer. They make this statement in that guidance document that VCTE or MRE are clinically useful tools for identifying advanced fibrosis in Nephal patients. They also go on to say that in the presence of metabolic syndrome or an elevated Nephal fibrosis score of FIB4, that liver stiffness done with VCTE or MRE can identify patients who are at risk of NASH or advanced fibrosis. This is a guidance statement from the AGA practice guideline, and here you're seeing they state that VCTE is superior to APRI and FIB4. And then finally, getting back to the Tapper and Locke publication in the New England Journal of Medicine relating to Nephal, using this same strategy of same-day VCTE and serologic testing, they're suggesting two possible combinations. Combine VCTE with FIB4, or combine VCTE with the Nephal fibrosis score, and again look for concordance and discordance. As a reminder, this is the Nephal fibrosis score online calculator using age, BMI, AST/ALT values, platelet values, and albumin values. Once they're completed, you would merely click the button to get the Nephal fibrosis score. Now, looking at the Tapper-Ofdahl publication, these are the high and low cutoffs that they suggest for those values. So here you see the Fib4 values, high and low, combining it with VCTE at 9.9 kilopascals. And here you see the combination of VCTE and the Nephal fibrosis score and the recommended low and high cutoff thresholds for that score. And again, we could apply that concordance, discordance, indeterminate value combinations from those two tests to work through this same algorithm that I was showing you previously when I was showing you hepatitis C. Finally, please remember that the AGA elastography guidelines for portal hypertension and esophageal varices apply to all liver disease, so those would still be applicable when we're in NAFLD. So last point, I want to stress the influencers of elastography. You know that when we perform VCTE, we're mechanically inducing a shear wave in the liver, and we're measuring shear wave speed, and then we're calculating stiffness. So we need to remember that when we do that, we are not measuring fibrosis. VCTE is a surrogate marker for fibrosis that nicely correlates, but it is vulnerable to other influencers of shear wave speed. If you were to say that fibrosis is the primary influencer of shear wave speed and liver stiffness, you would be correct. But there's two other important variables that you need to keep in mind if you're using those threshold values from the publications that I mentioned. First of all is hepatic inflammation. We know that an inflamed liver will test more stiff than a non-inflamed liver. Now, to some extent, the inherent inflammation in these diseases we've talked about are baked into those threshold values. However, if you have a patient with viral hepatitis and they're having a significant inflammatory flare-up, the inflammatory component would be more pronounced, and you should probably keep that in mind when you're interpreting the study, as per the guidance of Nephal. Finally, hepatic blood pressure is an influencer. We know that if you increase blood pressure in the liver, that the shear wave will travel more rapidly and that liver will test more stiff. This indeed is the basis for the meal restriction that's commonly used in VCTE, requiring that they have a 3-hour fast prior to the test. But you should also bear in mind, if you have a secondary factor such as right side heart failure, that could cause liver stiffness to be more pronounced than would be justified by fibrosis alone. So again, a final reminder, a great deal more information will be offered when Dr. Tapper does his webinar on November 1. All of you should have received an invitation to this. If you did not and you would like to be invited, you can follow up by merely sending me a chat message at the end of this event, and I'll be sure to get you on the invitation list. So that concludes my presentation. And we'd now like to move to question and answer mode. I want to introduce two of my colleagues who will assist me during the Q&A. First of all, I have Remco Inserink on the line. Remco is our manager of medical affairs, and he can comment on any aspects of research that might relate to your questions. And also I have Sunil Hasmeen with me. Sunil is a biomedical engineer who's an expert in non-invasive liver diagnostics, with emphasis on how they rate to pharmaceutical clinical trials. Sunil is going to be reading the questions, and then the panel will respond to them. Sunil, could you proceed with the first question?
Sure, no problem. And just as a baseline to everyone that's asking questions, thank you for the questions. In the event that we cannot get to them, please email Jerry. His email will be part of the follow-up email correspondence after this webinar for more follow-up on your specific question. I'd like to begin with something, Jerry, that you touched upon in the presentation because it's going to relate to a few other questions that have come up. So could you speak a little bit more about what are the secondary influencers of liver stiffness, which should be accounted for when interpreting a study or that can affect the study?
Yes, I mean, certainly it's very important to consider these secondary influencers. Anytime elastography is performed, be it with VCTE or with MRE, we are performing elastography. We are inducing a shear wave and assessing the speed that that shear wave travels. Now, we know from Hooke's law that as fibrosis develops, as a material gets more stiff, that the shear wave will travel at a higher rate of speed. But we also know that inflammation will have the same effect. We believe this is true because when you have inflammatory buildup in the liver, you're essentially raising hepatic pressure. And anything that raises pressure in that tissue will cause the shear wave to go a little bit faster. So what we're talking about with hepatic blood pressure is that same effect. We're raising hepatic pressure, and therefore the shear wave will transit somewhat more rapidly than fibrosis alone would indicate. Next question.
So along those lines, I think, and the only thing I'll add to that is this is a true statement for elastography in general. So there are things that affect the physiology of the liver, and this will also affect measurements in MRE as an example. So it's a physiological response. Piggybacking onto that original question, can you explain, maybe at a very high level, why there are differences in cutoff values for these different disease etiologies?
Yes, most certainly these various cutoff values come from very large series of research publications that are performed in each specific disease group. Obviously, it would not be legitimate to establish threshold values in one disease group and apply them to another disease group. So all of these threshold values are based on extensive research in those respective disease groups.
So I wanted to ask, I just wanted to tell the audience something really quickly. So I'm getting some questions pertaining to interest for the TAPR presentation. If you don't mind, if you could just send your email address as part of that question, that way we can kind of add you to the list. So that's going to take care of that piece. There's also a few questions here that pertain to be honest, very, very clinical questions. So questions that are actually more directed towards a clinician, a physician. And I'd like to table those questions for the TAPR presentation, because TAPR is a gastroenterologist, hepatologist who's best suited to answer that question. But here's a very good one that's pertinent to the discussion here. Are there any updates in the literature about how clinicians use CAP in terms of their clinical decision making? If you could answer some of that, and I have some follow up to that too, Jerry.
I'll provide some general information on this, but as Sunil suggests, we need to defer these to the clinical experts. For those of you that haven't previously listened to our one of our webinars, specifically on Nephal applications, I recommend that you go to our website, echosens.us, and you go to the clinical library. And one of the past webinars that you'll find in there as a recording is a webinar on risk stratification in Nephal performed by Dr. Steve Harrison. It has a lot of information on how to apply the values from both CAP and VCTE in Nephal. Now, obviously, this is a very dynamic field with a lot of new information coming out at a rapid pace. We are just days away from AASLD, and a good deal more information will be released at that meeting, to include a significant update from Dr. Harrison on the prevalence study that's driving a lot of the background data. We will arrange another webinar from Dr. Harrison as a review of what was revealed at AASLD on Nephal-NASH applications, and we hope to do that in a November-December timeframe. Everyone that was invited to this webinar will, of course, be invited to that webinar. If I can make a couple of suggestions on generally what is known, I've already talked about the VCTE applications in Nephal, and I've given you the published threshold values that we currently have. On the CAP side, I can provide a little bit of information. We have a good meta-analysis that tells us what threshold values appear to be legitimate for the CAP. And I'm displaying a slide now that's based on Carlos et al. From last year, in which they do a meta-analysis comparing CAP values to biopsy in 2,735 subjects. And what you're seeing here is they're showing a validated threshold value there of S3 steatosis of 280 decibels per meter. I'm sure you'll see that value move slightly as more information is published, but for the most part, that value will not move very much going forward because there's a lot of information in that value. Now, how might you use that? Again, I defer to Dr. Tapper and Dr. Harrison on this topic, but in general terms, what's being suggested is if you have a value in that range, that suggests a patient that might benefit from biopsy to determine if there's a NASH diagnosis, yes or no. So that's the primary application of that value as we understand it today, but there's still a lot more information to come. Sunil.
And just to piggyback off of that, if you look at a lot of these publications and including the most recent New England Journal of Medicine paper, it's really talking about risk stratification. Once you have a suspicion of NASH, is the patient advanced? Are they an advanced fibrotic? Are they cirrhotic? So those are sort of the discussions that occur within these diagnostic screening sort of strategies. But keep in mind that in order for the patient to fall into that pathway, it first must have a fatty liver etiology. So to define the patient as having fat in the liver is part of the definition of them being part of that Nephal-NASH spectrum. And in that sense, technologies like CAP are being used clinically to help identify whether the patient is in that realm or not. So ultrasound, CAP, these things that are beginning, MRI, PDFF, these things that are looking at fat presence in the liver, that's how they're beginning to be used clinically. Moving along, let's see here. Can you, so Jerry, I think you mentioned this as part of the AGA guidelines, but could you speak a little bit about how alcohol can potentially affect stiffness? How is it, perhaps affecting the stiffness measurement?
Yeah, specifically, we believe this relates to the inflammatory component. Obviously, an alcoholic who is drinking is going to have significant hepatic inflammation, and that inflammation is not allowed for in the AGA guideline for alcoholic cirrhosis. So again, there you see the value on the current slide of 12.5 as the threshold value for cirrhosis, but that value is only legitimate if the patient is abstaining.
And then to piggyback right off of that, how long do you abstain from before you can use the value specified in the threshold?
Typically, that time period is in the range of 6 weeks to bring down that inflammatory influence of the alcohol. We have time for one more question. We've reached our time limit. Do you have a final question, Sunil?
I think a lot of these questions are actually more geared towards the clinical aspect. So I'd like to table these questions for the TAP presentation if that's okay with everyone.
Very good. Sarah, back to you. Okay, I think we've lost Sarah's connection.
Oh, no, I'm sorry. I was on mute. This concludes the question and answer portion of today's webinar. And on behalf of Echosens North America, I'd like to thank you for your participation. This webinar has been recorded and the recording will be available for review on the Echosens North America website. That's www.echosens.us. And you will receive a follow-up email with a link to this recording as well. So thank you so much for being here. Have a great rest of your day, everyone. Bye-bye.